it's an honor to introduce our next guests. Don Jones has been around wireless healthcare. He was really one of the folks with Dr. Topol and Paul Saunier in the San Diego County, San Diego metro area that really did start bringing together this idea of digital medicine and digital health with Qualcomm and Scripps and all the good institutions there. And with him today is Sam Holliday, the CEO of Oshi Healthcare and one of the leaders in Virtual First. And given Don's national leadership, international leadership in Virtual First and really coining the term, we're going to let Don give a proper definition before he starts his interview with Sam and take it from here. Don, good to see you.
Hello, everybody, and thank you. Welcome. My definition of Virtual First care is the care delivered by an organization that is structured and designed to do everything they possibly can virtually for the consumer before defaulting to anything that looks like bricks and mortar. And that can include things like deliveries to home or in-home testing and that sort of thing as well. And to that end, I've today Sam Holliday with me, the CEO of Oshi Health. Sam, you want to introduce Oshi?
Sure. Yeah. So great to be here, especially with Don, who's been a big part of founding Oshi as the first full stack virtual clinic for GI disorders. So at Oshi, we really have built from the ground up, like Don was just saying, an experience for someone living with a gastrointestinal condition or experiencing chronic symptoms to come help get a diagnosis and then get ongoing care that can be delivered first virtually, and then really teasing out which services need to be done in person. And how do we design an experience that makes that start virtual for the benefits of convenience, more frequent touch points, and then appropriately navigate to the right in-person provider in a local market for the pieces that do require being in person.
So it's a little unusual to use the term full stack and healthcare delivery in the same sentence. So maybe you could break down what full stack services actually exist in Oshi, and when does the line get crossed that you have to actually seek bricks and mortar care?
Yeah, and part of the reason we're using that term is a lot of the solutions in digital health have been something that layers on top of care delivery. So it's been an extra add-on of coaching or in diabetes, you see the glucose monitoring with some kind of clinician or diabetes educator on the back end. The distinction we're making from those models is we are actually the care provider. So we have to go through licensure of our professionals state by state, setting up a medical group entity so that we can actually diagnose you, and then we can prescribe you therapy. And we think of therapy much beyond traditional medication. Because in GI, the role of food and what you eat can be considered a therapy, and your stress, anxiety, and depression need to be addressed as well, because they can trigger your GI symptoms, and your GI symptoms can exacerbate your mental health when the GI symptoms are causing you to withdraw because of the impact they have on your daily life. And so, we're able to deliver the full stack of the whole clinical team, from a gastroenterologist to a nurse practitioner to a dietitian and psychologist and a health coach on the front end, all on one team, one shared care plan, all through one place. Where today, often you have to go through a fragmented maze of in-person providers in different buildings, all with different schedules that don't necessarily coordinate the care for you to get access to the same group of services. So we're really trying to make it easy to access, but we can't do everything virtually. So to the point, we can't yet do a colonoscopy or endoscopy virtually, and those are important diagnostic and monitoring tools. And so for those types of services, we do need to find a really great, high quality and cost-effective local provider who can do those diagnostic procedures. And at times when infusion, for example, of a biologic therapy can't be done at home, or the patient's preference is not to do that at home, make sure we find somewhere for them to go get that medication infused. So those are really the two big buckets for us, where the in-person brick and mortar care is a must. And we want to make that a really seamless experience for our member to go from virtual to that in-person care and back to virtual.
So Sam, it sounds like you handle the arrangements differently than a typical office where they give you a business card and say, go call this office and set up your endoscope. Sounds like you're run a much more coordinated offering.
Yeah, and I think that's a big part of the advantage that companies that are building virtual first have. We're not tethered to fee-for-service incentive structures that orient toward things like procedures and medication infusions being the way they make money. And we can actually look at what are the full needs of the patient. And when you look at it with that lens, you realize some of the challenges in our existing system, which is what you alluded to often you'd go from primary care who did some initial testing on your GI condition, refers you to a gastroenterologist, you wait 2 months to get in to see a local GI, you see them, and let's just say they do a colonoscopy on you to diagnose irritable bowel syndrome. So a couple of things. One, you don't actually need to do a colonoscopy to diagnose irritable bowel syndrome in many cases, but it's always done because that's what we incentivize in fee-for-service and with our medical malpractice insurance construct. It's defensive medicine. But let's say you do that procedure and you say, okay, it's not inflammatory bowel disease or cancer. It's probably something like IBS. The next step, most physicians would agree, is to get dietary support. So a dietitian who knows how all the GI interventions around dietary. And you should, if you have stress and anxiety, see somebody to help you mitigate those factors. But fee-for-service has not created any incentive for gastroenterology clinics to provide those services. Maybe you can get them at the leading academic medical centers, but most care in the country does not have dietitians, psychologists, and gastroenterologists all under one roof. And so it leads to the fragmentation. My mom has IBS. She got handed a list of phone numbers for dietitians, none of whom ended up being covered by her insurance. No one even addressed the psychological needs with her. And so she was left to go figure it out on her own. And that's really, unfortunately, the state of care. But for us, we get to build it all from scratch and really design it around what a patient needs and put it all in one place in a coordinated fashion.
So Sam, about how you package all those services together up for payers and make that work in a non-fee-for-service.
Yeah, and that's really the key. You cannot, unfortunately, build these models with a fee-for-service construct because many of these services are not reimbursed. And if they are, there are often limits on the number of services that you can bill. And we think that is missing the broader point. And so we look at it and say, our goal is to get the outcome for the patient. And a lot of times with GI conditions, it takes time to unpack what is the root cause of the symptoms this person is experiencing. And it's very personalized. Don, you and I could be eating the same foods and getting very different responses from our GI systems. And so it takes that detective work, that time, the frequency of touch points, and then going through a structured process with a dietitian to figure out what your trigger foods are. And it could take time with a psychologist or therapist to put in place the self-management tools around mindfulness and stress and anxiety reduction. So we've packaged it all up and said, for a fixed monthly price, you get unlimited access to care through Oshi Health providers of all of those types. And we will coordinate the in-person care as the second option and make sure that we coordinate that in a way that is cost effective and ends up getting the patient to the right provider. For example, keeping some of these services out of the hospital where the cost can be 4 times for a colonoscopy done in a hospital what it is in an outpatient center. And as the person or the entity paying for care, that doesn't really make sense as long as the experience and the quality is the same for the patient. And so we're able to help navigate these and package it up for the payer to reduce total cost while improving quality of life, workplace productivity, and satisfaction of their member.
Sam, so virtual all-you-can-eat model, no pun intended.
Right.
Maybe just to close, you could share a couple of comments from some of the patients that you're hearing in terms of how they're reacting to the Oshi service.
Yeah, and I mean, honestly, it's the most rewarding part of what we do. It keeps us all going every day, but we get amazing feedback, people saying, I've been trying to get help for this for years, and all I ever get is this, handoff to go find a dietitian. And people have tried that, and it's either not been reimbursed, or they've found a generalist dietitian who just doesn't know the GI interventions that well. And so they've been just blown away at the frequency of touch points, the level of support, the GI specialization of our care team, and the convenience of being able to do it from home, and do it, on their schedule. And we have much more frequent appointment availability as well, because we can build a scalable model, with a virtual approach. So really amazing feedback. People just saying, I've not been able to get this level or quality of care anywhere to this point in my journey.
Thank you very much, Sam. I don't know if we have any time for questions, Stan, but I appreciate the opportunity to help present Oshi Health.
We certainly do. I think we've got a few more minutes here, and just based on the some of the chat room questions, and then some of the questions that we picked up on LinkedIn prior to the symposium, looks like people are really interested in understanding what are the obstacles to this, based on 3 decades, 4 decades of what they've seen over the kind of the evolution of the U.S. healthcare system. You two are at the forefront of this. What are you seeing as the big barriers to virtual first becoming a reality?
Well, I think, Don has been part of founding an amazing group of virtual first companies under the brand Impact, co-hosted by the ATA and DIME, the Digital Medicine Society. And all of us are coming together for this exact reason. We're all facing barriers. I broadly bucket them into, there's legal regulatory barriers like state licensure, corporate practice of medicine laws, to deliver care in this way, which is not, it's sort of taking the local aspect out of it intentionally, but we've really designed a lot of our laws to keep healthcare very local. And so some of those laws get in the way of expanding this model across state lines and to bring it to bigger populations. So that's one. And two, I think the reimbursement side is absolutely a huge barrier. I think it creates an opportunity for us to skip an entire generation of transition and just go more directly to what looks like value-based care, because we don't need to also fit in fee-for-service as a construct. Don, I don't know if you have other thoughts there.
I think it takes a long time. We've got 3,000 health insurers in the United States. It's a lot of doors to knock on to make sure you have coverage. I think the concept of a bundled treatment is not new, and frankly it's understood. It just takes some time to sell it and contract for it and put it into place. And I think that's, at the end of the day, the biggest hurdle is just that amount of time to put that in place. And while you're going through that process, you have coverage for, not for all, and that creates a little bit of a bumpy road.
And Stan, actually, one more thing, and I just saw someone ask this. The topic of what evidence is required is a really interesting question, because when I get asked, well, what's the evidence that Oshi Health's model works? I can send them all the clinical trials that have been run on the interventions that we use. All we're doing is translational work into a different way to deliver those same interventions. We're using the same protocols, same approach. We're just doing it through telehealth, like this, webinar and Zoom interaction. And so I think the question we have to ask ourselves is, do I need to show in a randomized clinical trial controlled study that our care model works better than brick and mortar? And who can show me the evidence that brick and mortar at every institution is getting the better outcomes? The reality is, it's a really interesting question that we'll also tackle through Impact. Someone asked if we're running a clinical trial. It's actually launching today. We're running a clinical study with a payer to show how our model of care works against a control population that's getting standard care in the exact same markets. It's in the fully insured book of a health plan across a couple of states. So it's an exciting day for us at Oshi to kick this off, but it is a topic we'll work on at Impact.
That's wonderful. And yeah, and thank you, Don, and certainly thank you, Sam, and good luck, Sam, in running this. It's doing a startup is one thing. Doing a startup where you're in the midst of a massive transformation of a major part of the U.S. economy, roughly 20%.